day-to-day practice. So in the next 20 minutes, what can we do, how to approach a child with a developmental delay, we shall see. So development means it is the acquisition of new skills, how a child is able to do more complex things as he or she gets older. And milestones are a set of functional skills or age-specific tasks that most children can do at a certain age. And we know the principal domains in the milestones, and nowadays gross motor and fine motor is considered together, and additionally ADL has to be included in the domains of development. And language, as you see, it includes both receptive and expressive language. Now what are the general principles of development? It is a dynamic process which occurs that over a trajectory, and it follows a cephalocaudal pattern, and there is a rapid acquisition of new skills followed by a period of practice and consolidation. So for the examiner or for the practitioner, it may be seeming as it remains plateau, and it depends upon the neurological maturation and also influenced by the general environmental factors. And we should also remember that each child is unique. He or she develops at his own pace, and each child is an individual, and there is a wide range when a child achieves a particular milestone. And two children born on the same day may learn the same skill months apart. So when skills do not emerge as expected on a broader schedule, then we have to concern about it. And often there may not be a delay at all, and it may be a preterm child who would catch up with the growth and developmental milestones, and there may be a transient plateau during intercurrent illness, and there may be a lack of opportunity to learn. So we have to remember all these things whenever we come across a child with a developmental delay. There are certain terminologies. When will we call it as a developmental delay? When there is a significant delay, more than 2 standard deviation, lower than for that particular mean on age appropriate testing. And developmental dissociation is when there is a gross discrepancy between different domains. Why there is a need to recognize all these things is, whenever there is a gross delay in acquiring the motor milestones, whereas the other milestones are normal, then our first differential diagnosis will be neuromuscular disorders. Whereas if there is a delay in the social milestones and language milestones, whereas the motor milestones are normal, we have to think about pervasive developmental disorder as the first thing. Hence, we have to acquire, or we have to examine, or we have to look for whether there is a discrepancy between different domains. And when we say developmental regression, that means it is a loss of acquired milestones. And the types include a global developmental delay or a specific delay. Global delay is significant delay in 2 or more domains in children aged less than 5 years. And we can use the term intellectual disability when the child is more than 5 years old. And as we know that developmental delay is not a diagnosis, it's a symptom like a cough or cold or a vomiting or a headache. And we should ensure that there is no regression of milestone. Whenever there is a specific delay means there is a domain in a single domain. So the literature says the global developmental delay globally it affects 1 to 3% of children worldwide, out of which 2/3 are mild to moderate and 1/3 are severe, and about 1% of the children have pervasive developmental disorder complex, and 5 to 10% have a specific learning disability. So what are the warning signs? If the child doesn't support his neck well by 5 months, doesn't reach for objects by 7 months, or doesn't roll over by 7 months, can't sit on his own by 9 months, and can't crawl or stand even with support by 12 months, and cannot walk independently by 18 months, then it is a warning sign. Coming to the cognitive domain, not searching a hidden object or no gesture or pointing by 1 year, doesn't follow instructions and doesn't imitate by 2 years, again it's a warning sign. Social domain, doesn't smile at the people by 3 by 12, no laugh by 6 months, no affection for the caregivers by 7 months, no interest in the peekaboo game by 8 months, no gesturing by 1 year, we have to evaluate. So these social domains may be faulty, or maybe due to the ineffective parenting or a parental neglect, or it could be a pervasive developmental disorder. And among the language milestones, suppose the child doesn't babble by 3 months, no response to sounds by 7 months, not even a single word by 1 year, or no 2-word phrases or less than 15 words in 2 years, we have to evaluate. Maybe the child is exposed to more than one language polyglot, or maybe an underlying hard of hearing or a learning disability, or maybe a pervasive developmental disorder as well. Coming to the visual, suppose the child is not following moving objects by 3 by 12 or a squint by 6 months, then we have to subject the child for an detailed ophthalmological evaluation. There may be a cataract, media opacities, or an amblyopia, maybe due to an optic atrophy or a cerebral visual impairment, or it could be due to a complication of retinopathy of prematurity as well. Coming to the other red flags, whenever a male child not walking independently by 18 months of age, then this child should undergo serum CPK to rule out an underlying delusion. Early handedness, whenever the child is preferring only one hand for reaching for objects before 12 months of age, this could be a sign of hemiplegic CP. And excessively floppy, maybe SMA, excessively stiff, early CP, early hand control. Maybe the parents will be very happy that my child has developed an early head control, but as physicians we shouldn't be happy. This is a dystonic head or dystonic neck which might refer to an maybe an infantile gaucher or a Krabbe's disease or infantile Niemann-Pick. And abnormal startle, whenever the child startles with every sound, for each and every sound, doesn't habituate, then this is an abnormal startle. We have to think about whether could it be an GM2 gangliosidosis, GM1, pyridoxine dependency and sialidosis. Walking on toes may be habitual. Some of the ASD children, that is autistic spectrum children, they do walk with tiptoe walking, but whenever it is persistent, then we have to consider whether it is a diplegic CP, at times even in muscular dystrophies. And the most important thing is, the next thing is movement disorder in less than 1 year of age. Normally a dystonic CP or a choreotytoid CP, for that matter the extrapyramidal CP, they develop the movement disorder only in the second year of life. During the first year, they will behave as a hypotonic CP. So whenever a child is having any type of movement disorder less than 1 year of age, we have to rule out an underlying IEM. So these are the other red flags we have to consider in a child with a developmental delay. Then comes the developmental assessment. This is a part of comprehensive every child care visit. The objectives include to ascertain whether there is a delay, and to arrange for interdisciplinary rehabilitation, to counsel the family, to address the comorbidities, and of course we have two types. One is surveillance, which is a longitudinal one, and a developmental screening. Again, in this screening we have definitive tests and other one is screening tools. These things will be discussed tomorrow in a detailed manner. There is a separate session on this developmental screening tools. So coming to the causes for global developmental delay, either it could be a genetic syndrome, chromosomal disorder, cerebral dysgenesis, endocrine problems such as hypothyroidism, or an intrauterine infections, toxins, or environmental. So coming to the history, what are we going to ask from the parent or the caregivers? A 3-generation detailed family is the first and most important preliminary step, and we have to, if there are, we have to go through the photographs of the other affected family members. That may be helpful, and serial photographs in a chronological order may assist in identifying the diagnosis, because all the signs may not be there evident at a particular point of time. The child may develop a new clinical symptom or a sign later also. And in the history we know pretty well what are the high risk factors. All these things we have to ask, and most important things will be whether there was any history of SIDS or abortion or infantile death. Abnormal startle, as we have already discussed, abnormal odor of urine, which can say that it could define that it could be underlying inborn error of metabolism. And again, whether there was any metabolic decompensation during intercurrent periods of illness, that again denotes that the child is having an underlying inborn error of metabolism. Any chronic illness in the child is like CKD, CLD, or any possibility of psychosocial deprivation, again we have to ask for symptoms suggestive of pervasive developmental disorder. And again, the history should as well include the comorbidities, seizures, visual difficulty, hard of hearing, feeding difficulty, and behavioral disturbances. Coming to the examination, a detailed physical, dysmorphological and neurological examination using a head-to-toe approach is essential, and we should have the photographs of the child should be obtained with informed consent from the parents for further discussion with the colleagues and with the specialist. And we should always reassure the parent that confidentiality and anonymity will be maintained at every level at all times when discussing this particular children's clinical findings and photographs with our colleagues. The clinical examination or head-to-toe examination we may come across such things: hypertelorism, hypothyroidism, and a depressed nasal bridge as seen in the Down syndrome, or a broader nasal bridge, or a synorphis with an long eyelashes as in a cornelia de Lange, a microcephaly or a macrocephaly, another child with macrocephaly with an Canavan's disease, coarse phases of a hypothyroidism or in an MPS, alopecia, seborrheic dermatitis in a biotinase deficiency or in a Menkes, midline facial defects which can denote that it could be, that could be an underlying holoprosencephaly. And we may come across certain genetic syndromes. By seeing the child itself, we can diagnose them. For example, Down syndrome and trisomy 18 with the rocker bottom feet, short stature, obesity, Prader-Willi. Here you can see two siblings with the microcephaly with the photosensitivity and all with the pinch dose Cocaine syndrome. And in the limbs, there may be polydactyly or maybe a syndactyly, clinodactyly, simian crease, and there may be a broad thumb and a great toe which comes in a Rubinstein-Taybi syndrome with the microcephaly. And we should look for neurocutaneous markers as well. Ashleaf macule, the first big cartoon shows you the Ashleaf macule, the second one adenoma sebaceum of a tuberous sclerosis, port vein stain of a Sturge-Weber, multiple cafe spots in a NF1. And voles of hyperpigmentation, especially involving the axilla and incontinentia pigmenti, midline facial nevi in an epidermal nevus syndrome with a hemimegalencephaly, and prominent Mongolian spot in a GM1 gangliosidosis. The eye is the window of the brain that we know. So a good ophthalmological examination can give you so many clues for in a child with a developmental delay. There may be a cataract, we should look for a cataract, corneal clouding, lens dislocation can occur in homocystinuria, sulfite oxidase, molybdenum cofactor deficiencies, Cherrett spot, chorioretinitis scar, and RP. So the neurological examination should include dexterity, that is the handedness, comprehension, language, cognition, gross motor, fine motor, and activities of daily living, gait, as well as should include the cerebellar signs, look for cerebellar signs and involuntary movements as well. So there is no one size and fit all algorithm. Each child we have to evaluate and go through the child individualized management, and there should be a syndromic approach. As a step one, when we have satisfied ourselves that this particular child is having a developmental delay, the first and foremost step again is make sure that there is a delay, detailed history and methodical examination, ophthalmological exam opinion and a hearing evaluation is a part of evaluation of a child with a developmental delay. We have to, apart from the blood sugar, RFT, LFT and all, these four things are very important: thyroid profile, ferritin to rule out an iron deficiency anemia, vitamin B12 to rule out a vitamin B12 deficiency, and biotinase deficiency. This is all these things are treatable causes of developmental delay. Serum uric acid, high uric acid denotes an Leishnihan. Serum CPK has to be done whenever a child is having a delayed walking or proximal weakness to rule out underlying muscular dystrophy. And if we, on examination, if we suspect a specific etiology such as neurocutaneous syndrome or a genetic syndrome, chromosomal disorder or a metabolic disorder like IEM, then specific tests must be carried out. Otherwise, we have to, in all severities and grades of mental subnormality, intellectual disability and global developmental delay, the next investigation will be a chromosomal microarray, karyotyping and FISH. And in moderate to severe global developmental delay in a female, these children has to be subjected for MECP2 gene testing to rule out Rett syndrome. And if it is a mild global developmental delay in either gender, FMR testing to rule out underlying Fragile X syndrome has to be done. And the first line metabolic test should include your serum amino acids, acyl quarantine profile and urine organic acids. So chromosomal, just a few words about these tests, because we have a separate session on genetic testing for children with a developmental delay tomorrow. Chromosomal microarray is considered as the first line genetic test in all individuals with global developmental delay and intellectual disability. The diagnostic yield, it is otherwise called a molecular karyotyping. The diagnostic yield is 15 to 20%, whereas in plain karyotyping it is 3 to 6. And it identifies submicroscopic deletions and duplications. But there are some pitfalls. It may identify variants of uncertain significance, which may be difficult to interpret, and it may not detect these balanced translocations, inversions, ring chromosomes, and low-level masochism. So to identify these defects, standard karyotyping is required. If we are suspecting methylation defects, then specifically we have to ask for FISH, and we have to write that we are suspecting methylation defects like Prader-Willi, example Prader-Willi and Angelman. So the next step only is the neuroimaging. So a plain CT may show abnormalities in 1/3, whereas the MRI brain is more sensitive. It can show abnormalities in nearly 50% to 2/3. And the MRS is also useful, we will see in the next slide. So the diagnostic yield of MRI will be higher if it is used whenever the global developmental delay is associated with epilepsy, focal neurological signs, microcephaly or macrocephaly. So then comes your detailed other metabolic tests. Serum lactate, pyruvate ammonia, CSF lactate may be useful to find out underlying mitochondrial disorder. Serum transferring isoelectric focusing to diagnose congenital disorders of glycosylation. Plasma, very long chain fatty acid, piperacolic acid, phytanic acid, RBC plasmalogens to identify peroxisomal disorders. Serum 70-hydrocholesterol to identify cerebrotendinous xanthomatosis, in which it will be very high, and low serum cholesterol will be very low. Urine guanidins to identify cerebral creatine deficiency syndromes, and blood and skin fibroblast assay for lysosomal enzyme assay to rule out, to diagnose underlying lysosomal storage disorders. And we may have to carry out CSF neurotransmitters to diagnose neurotransmitter deficiencies. And what is the yield of metabolic screening? A routine screening will yield, the yield is only about 1%. But if we do methodically, if there are clinical indicators in that particular child, the yield increases up to 5%. When we do it in a stepwise manner, then the yield increases to about 14%. So little words about other genetic tests. Clinical exome sequencing is rapidly becoming a key diagnostic tool, and we are with the whole exome sequencing and whole genome sequencing is going to revolutionize the diagnostic process. But all these omic medicine is likely to turn this paradigm on its head with the whole genome and the sequencing, identifying genes which may be causing the phenotype in that particular child. So this is going to be a reverse dysmorphology. Often we are getting VUS, and then with the genotype we have to match the phenotype, whether this genotype is matching with the present given child or not, we have to look for. So let us see certain clinical examples. This particular child, delayed standing and walking, language delay, behavioral problems, discolored hair, microcephaly. Other things are normal. And you see in the MRI just periventricular white matter changes diagnosed as or reported as HAE. But when we did the TMS, it shows a very high phenylalanine levels. So now you know the diagnosis. It is a classical PKU. Second case, again developmental delay, language motor delay, language delay. There is a family history of significant family history of developmental delay and intellectual disability in the family. Many members, maternal uncle, maternal grandmother, her brother, so many people were affected with a developmental delay and intellectual disability. And this MRI, if you see the MRI, you can appreciate that there is an involvement of bilateral globus pallidus and midbrain. You can see the diffusion restriction in these areas, that is intramyelinic edema, and this is very classical of MSUD, maple syrup urine disease. And TMS showed very high levels of leucine isoleucine, so MSUD is confirmed. Third case scenario, again motor delay, language delay, whereas this social and language delay were more affected. These domains were more affected than the motor domains. Child had autistic features, microcephaly. The plain MRI was normal, but the MRS showed in the left one is the right one is the normal. You could see NAA peak, and then one creatine peak, then one is the choline, and again a creatine peak. Whereas the left one shows only 2 peaks, that is NAA and choline only. There is no creatine peak. So this is confirmatory of a cerebral creatine deficiency disorder. Molecular analysis showed a homozygous variation in the GAMT gene, one of the cerebral creatine deficiency disorder. Hence, in any child with an unexplained developmental delay, it is prudent that we include MRS as well whenever we are asking for an MRI. Again, MRI may show typical abnormalities in certain cases, like in this child, a global delay, artistic features, nystagmus, and seizures. Your MRI shows a typical molar tooth appearance. This is the Joubert syndrome. Another child did not attain head control or rolling over, irritable, inconsolable cry, having a neck retraction, oppositonic posturing. This is the child, and this MRI shows and white matter changes in the posterior aspect with some amount of thalamic involvement, and you can see that it is a Krabbe's disease. Yet another child, yet to achieve head control, dysmorphism, hepatosplenomegaly, prominent Mongolian spot, skeletal survey showed dysostosis, cherry red spots were there in the eye. So it is a GM1 gangliosidosis. Floppiness since birth, generalized hypotonia with the preserved reflexes, you can see the floppiness, you can see in the X-ray there is some cardiomegaly. So this is a Pompey's disease. So, and moreover, whenever we come across children like this, it is not that all the time it will be having some neurological disorder. We have to be careful, we should do one proper head to toe examination. Here this child has been referred as a global developmental delay. You could see there is a hyperpigmentation in the sole, as well as you can see the nails, they are pale. This turned out to be a vitamin B12 deficiency. Yet another child last week referred to our OPD as a motor developmental delay. On examination you could see an wide wrist, and as well you could appreciate a rachitic rosary. So this is a case of it, this turned out to be an rickets. So there is no harm, or it is not harmful if you miss a exotic genetic syndrome. But if you miss these treatable causes for developmental delay like nutritional deficiency, then it is a big omission, or I can say it is a negligence. So to summarize, developmental surveillance should be a part of every visit. There should be a pragmatic and a practical approach for a child with a developmental delay. Proper history and examination is halfway through the diagnosis. Investigations should be individualized, and each child is unique, and always heed to the parental concerns, allay their fears and reassure them. Thank you for the patient hearing.